Welcome and good morning. Hi, I'm Ali Khan, Dean of the College of Public Health here at the University of Nebraska Medical Center. And I'm delighted that you're joining me on this Science Cafe. So boys and girls, ladies and gentlemen, I'm going to tell you a story today. And this story is about the new viral king and how we're going to take a little portal to the new world at the end of this. So like all good stories, my story starts down?
Right.
Right. Yeah. My story starts a long, long time ago. So once upon a time, about 10 to 12,000 years ago, when people were no longer hunter-gatherers, they came together and they started farming. And they started domesticating animals. And as they came together, all of a sudden, there were enough people to sustain a disease that went from person to person to person. And they ended up getting diseases from their animals that came to them and infected them. And that's how we got the first great plagues of humankind. So if you think about measles, that was probably a disease of cows that made their way into humans. If you think about smallpox, that was as we started to store grain, probably the rodents showed up to eat the grain, and one of their viruses made their way into humans, and that's how we got smallpox. So I call this the first epidemiologic transition of the era of the Great Plagues. There were other great epidemiologic transitions, and if you want to learn about those, there's a paid version of this course called an M.P.H, and please be free to come and join us here at your College of Public Health to get an M.P.H. So this is where my story starts, about 10 to 12,000 years ago, and in the era of the Great Plagues. But those Great Plagues continued. And they continued over time. So let me fast forward you to the mid-14th century. So 1347, 12 ghost ships make their way. This was the real plague, and literally the plague that we call nowadays, and took about probably a quarter of the European population, caused a severe socioeconomic political upheaval of the whole social system at that time. Let me fast forward you another 400 or 500 years and take you to this great plague. This was the 1918 influenza pandemic. Here in the U.S. alone in 1918, 750,000 people died from influenza. And influenza has continued to worry us because this virus has a nasty habit of what we call shifting and drifting. And so every couple of years, it changes its molecular structure, its outer coat, which is why you need a new vaccine every year. But it has a nasty habit occasionally of completely changing its outer coat, and we need a brand new vaccine, and we have no immunity to which we have no immunity, and it can cause a real pandemic. And this 1918 pandemic is what most infectious disease epidemiologists really worry about, having another version of this 1918 pandemic. And here I decided to show you a newspaper headline from Seattle, and Dr. J.D. Tuttle actually is well known to us in the public health field for his work for influenza in those days. Let me take you to another pandemic. This was 1981. And this was the first report in Los Angeles. There was another report from CDC that came out very shortly looking at pneumocystis pneumoniae. And as everybody knows who's listening to me right now, this was the first report of HIV. And this was the global HIV pandemic. So another pandemic that unfolded. Now all of these pandemics, oh, sometimes my smart board works and sometimes it doesn't. So there's a characteristic of all these pandemics, and now hopefully everybody picked up on those. These were all associated with animals. So the Great Plague was rodents and fleas. Influenza is the natural host for influenza viruses are wild fowl, and they can mix with pigs before they infect you. HIV was probably a non-human primate, probably through bushmeat. Somebody got infected in Western Africa, and that's how the disease then eventually spread to humans, and then in humans through sex and blood. So that was HIV. So all of these are zoonotic diseases. The word was originally used and coined by the Pope of Medicine, one of the greatest pathologists of all time, Dr. Rudolf Virchow, back in the late 1882, by the way, but in the late 1800s, and these are diseases of animals that spread to humans. And most of the microbes that infect us actually come from humans, and actually 75% of these emerging diseases that we get infected with are animal diseases that make their way into humans. So let's talk a little bit about these emerging infections. So this slide breaks every rule of slides that you're told, which is it's way too busy, but that's actually the purpose of the slide, is to say that if I try to explain to you all emerging infections over the last 30 years, what I would get is something that looks like this, right? It's like, it might as well be a Rorschach test, you know, it's like names all over the place. But these are, over the last 30 years, all the various diseases worldwide that have either been newly emerging or re-emerging worldwide. And many of them you'd recognize if I pointed them out to you. So if we were having this conversation in 1999, I would be talking about West Nile virus, which we never had in the United States. Now everybody recognizes, oh yeah, we have West Nile across the United States. More recently, we've seen outbreaks of measles across the United States because people have not been vaccinating their children. We've had outbreaks of acute flaccid myelitis in the United States due to adenovirus. My original career in the United States as an EIS officer at CDC started with hantavirus pulmonary syndrome, which is a rodent-borne disease in the southwestern United States. So this goes on and on. Zika virus, which fortunately caused very little disease in the United States. Of these, the only pandemic, and we'll talk a little bit more about that, was H1N1 in 2009. But the other ones caused localized or regional outbreaks, so the Ebola outbreaks, for example, are in here. But there's a very interesting one in this list here in my slides, and you'll see SARS here. And we'll talk a little bit more about SARS in a minute. So these are the emerging infectious diseases that continue to plague us. Superbugs. We hear a lot about superbugs, so hello superbugs up here. So let's talk about that little comment about SARS over there. So people have been talking about how this new coronavirus, novel coronavirus that causes COVID-19, coronavirus infectious disease 2019, is a black swan event, something we could have never predicted. Well, we actually had the same novel coronavirus, closely related novel coronavirus, in 2002, 2003, and at that point we called it SARS, severe acute respiratory syndrome. This was a virus that again originated in China, made its way into Hong Kong, and then spread worldwide. In that time, it spread to 30 countries. It took us about 6 months to shut it down. Caused at that only 8,000 odd cases at that time. But we had an outbreak due to a novel coronavirus a decade and a half ago. Now, some interesting features about SARS, which I want to talk about. Our first experience with this novel coronavirus. So, which are important to us as we talk about our current experience with this coronavirus. So the first is that these types of viruses within this category are really good at causing something called super spreading events. And what that means is, while these viruses usually infect maybe 2 or 3 more people, sometimes they can infect 10 to 15 to 20 more people. Right? And we don't understand why these events occur, but these super spreading events are really very effective in spreading the disease much more widely than you would expect and make the outbreak more difficult to control. And so here's lots of examples of individuals who cause these sort of super spreading events whether it was at a hotel. So this is a famous outbreak at the Hotel Metropole that's spread cases to multiple countries. And then these are additional outbreaks in various sites. The Hotel Metropole outbreak I know very well because I spent 3 months in Singapore responding to the SARS outbreak, where we redefined quarantine and isolation in those days for this new generation, and these are techniques we're using again today. But you know, these outbreaks in Singapore especially, and I wrote a paper about that describing these super spreading events, was really driven by these super spreading events that just kept this outbreak going on and on and on, whereas otherwise we could probably have wiped it out a lot earlier. But super spreading events, and then healthcare workers, very infectious to healthcare workers. Now, not just SARS, but these coronaviruses, there's another disease associated with it called MERS, and this is Middle East Respiratory Syndrome, very related to SARS, and it started in the Middle East, and this is an outbreak in South America, and this is an individual in 2015 who went to a business trip in Bahrain and Saudi Arabia, came back to South Korea, and the graphic's interesting, but the only point for the graphic is to say that there's a whole bunch of healthcare workers infected, healthcare worker 1, 2, 3, 4, etc., etc., etc. This went into 3, 4 different hospitals. They also had the same trouble with these super spreading events of one person infecting a whole lot of additional people. So these viruses are known for causing healthcare infections, infecting healthcare workers, and they're known for causing infections in healthcare settings, of course, and they're known for causing these super spreading events. So it makes them very difficult to get under control. But that was our experience with these novel coronaviruses before this current one. All right, let's go to, so why these emerging infectious diseases? What drives these emerging infectious diseases? So I talked about the first set of these. So these are zoonotic diseases. So ecological change is the main driver for these, right? And so what drives this ecological change? You know, climate change, without a doubt, is a factor as we think about how these, if you think about the animals, if you think about the mosquitoes or the ticks or the fleas, you know, temperature, humidity, all of that's going to drive where they move. And that's going to drive your interaction with them. Deforestation, you know, where are you going? Rapid urbanization, and yes, I know it should be rapid urbanization, but I leave it as rapid on purpose urbanization. As you concentrate more and more people together, it's a lot easier to get disease transmitted between people because there's just a lot more people in one place, right? Increase in global travel, no doubt about it, right? So once upon a time, even now, we are protected by something wonderful called an incubation period. So if you get infected, unlike the movies, you don't immediately get sick. It takes a while to get sick, and that's called an incubation period. So if you have to take a ship, you know, to go from whatever, from London to New York, well, by the time you get to New York on a ship, if somebody's infected with something, you know they're infected, right? And that goes back to the great service I was in, the U.S. Public Health Service, that used to quarantine ships. However, if you take a plane someplace, you could be infected with the disease, show up in a country, be absolutely fine when you show up at the airport, and then a couple of days later when you're home is when you manifest the symptoms of that disease. So air travel has markedly made it easier to spread infectious diseases worldwide. And you've seen this with this outbreak, right? People showing up at home, showing up in the airport, absolutely fine, you check their temperature, but then they get sick afterwards and then spread disease within their community. So air travel has definitely made that easier. Vectors, so these are mosquitoes, etc. Their resistance patterns, obviously we've talked about superbugs, so their resistance patterns matter. Humans also, our resistance changed. So 100 years ago, we probably didn't have as many people on kidney transplants, renal transplants, immunocompromising conditions. So we're more susceptible now than we would have been before. And then probably the biggest reason is political choices and how we establish our public health systems, how we establish our healthcare systems. And those choices determine whether or not a disease is going to emerge within our community. Nope. Sometimes it works. All right. So, I have whole presentations on why we need to prepare. I don't need to give that presentation. Everybody knows why we need to prepare, right? So, influenza has always been one of our major concerns, that we could have another 1918 influenza pandemic. And in 2004, bird flu, which is avian influenza, was a major concern for us in Asia as it was spreading across the world. And we were concerned that this could become the next pandemic, and there was a lot of work in the U.S. to get ready for a next influenza pandemic. We were lucky that instead of getting this severe avian influenza pandemic, what we ended up getting was a milder swine flu pandemic that started in Mexico and spread in 2009 from the United States worldwide. And so we did have a pandemic in 2009, and I thought I would share this from you that says, why you'll be wearing masks again. And it turns out this author got it right? The world may have dodged a deadly flu pandemic this time, but you won't be so lucky. So the author got it spot right. He was thinking that we were going to get another flu pandemic, but unfortunately, instead of flu, it was something else that did have us wearing masks again. So as I said, I had lots of slides like this, and I put an old one up that would try to convince people we need to be prepared. But nobody now needs convincing why preparedness is the best bet. And it's not just the health impacts, it's the economic impacts, as you know, and it's the social impacts and political impacts that we will have globally from a pandemic. When I was at CDC, one of the questions I always got was, how prepared are we for a pandemic? And so working with the Robert Wood Johnson Foundation, state and local health departments, we created something called the National Health Security Preparedness Index to try to give a sense to Congress and others of how prepared was the United States for a pandemic. And you will see here, so there's a couple of different domains, but you'll see here that in 2019, we said our preparedness level in the U.S. was 6.7 out of 10, okay? So while we had made progress since 2013, it was still quite low, and you'll notice that one of the lowest numbers for our preparedness was healthcare delivery, 4.9. And this outbreak has proven that healthcare delivery was where we were weakest in for our preparedness here in the United States. Now, given how low the U.S. was ready for an outbreak, good friends of mine, at the Nuclear Threat Initiative at Hopkins and at The Economist said, well, let's take what you did for the U.S. and let's scale it up for the world and see how prepared the world is. And you'll notice that the U.S., with their 6.7 out of 10, counted as best prepared, and the rest of the world counted as not so well prepared, except for some select other countries. But the bottom line is, none of us were prepared for the pandemic, and it's played out. You've seen it played out in the newspapers, on TV, on the radio. We were not prepared for this pandemic, and we are paying the price for not being prepared for this pandemic. Okay, the great empty of 2020. Okay, so let's talk a little bit about the pandemic. So the pandemic starts, and it starts probably sometime in October, November, probably. The cluster of cases is identified in December by some astute clinicians. As always, we depend a lot on astute physicians, nurses, others in the healthcare system to say, you know what, we got a couple of patients that just don't make sense. They have been what's atypical pneumonia, right? This pneumonia doesn't make sense. There's too many of them. They all seem to be coming from the same place, in this case a seafood market. They seem to be infecting other people. So it was recognized within the Wuhan in Hubei province in China. But the world first became informed of this outbreak on 31st December in Hong Kong, when the Wuhan Municipal Health Commission announced that they had 27 cases of viral pneumonia that they were pulling out into a new hospital. So they were moving all these cases into a new hospital for investigation. And kudos to Ian McKay. This was, I guess Ian put this together on 3rd January from Italy, from Ian's from Australia. He helped put this slide together. But at that point, the news was 27 cases, 7 critical, no human-to-human transmission. All believed to have visited the seafood whole food market. A couple of days later, I think they updated this to 44 cases. No human-to-human transmission. No, it's not SARS. We've closed down the market. No, no healthcare acquired. No healthcare cases. Nothing to worry about. Nothing on this slide is correct. But you can nothing on this slide is correct. But you can ask those questions during the question section. So let's fast forward past this slide then.
Great.
Let's fast forward to today. This nothing to worry about slide transitions from nothing to see here, nothing to worry about, transitions to today to 2.5 million cases worldwide, at least that have been identified, recognizing all case impact worldwide with 168,000 deaths. Again, a lowball estimate. Worldwide, 185 cases. So this is everywhere. All right, so that's where we've gone in a mere 4 months of this disease. Okay, that's fast. Okay, and that goes back to everything we talked about a couple of minutes ago. So let's see now if I can tie together all those threads of emerging infectious diseases, zoonoses, factors, pandemics, etc. Okay, so here we have this new coronavirus. Let's see if we can make sense of this. So the coronaviruses, I started this talking about the new viral king, right? So corona means crown, and if you look at this virus, there's little spike proteins coming off the end of this virus, so it's called a crowned virus. So I call this the new crowned king, the new viral king. So this viral king, there's a number of viruses within this family. Actually, 4 of them cause the common cold, okay? We're not worried about the ones that cause the common cold. We're worried about the ones that cause severe respiratory disease in humans. We already talked about SARS, that SARS coronavirus 1 that causes SARS. The natural hosts for these viruses are bats. That goes back to the zoonotic animal aspect. So the natural host is bats. And for the SARS outbreak, the bats in a wet market, so this is where people come together to buy their animals, and it's not just, my kids, as far as my kids are concerned, their chicken comes, wrapped in plastic from the local A&P or Kroger, right? But in other parts of the world, you go get your live chicken, you get your live bat, you get your live civet cat, whatever. So civet cats to humans for SARS. MERS in the Middle East, probably the bats infect camels, and then the camels infect humans. For this new SARS coronavirus 2, which is causing this COVID-19 coronavirus infectious disease 19, that's a clinical disease. This is the virus. Likely pangolins, also in a wet market, likely infected a human. So this whole outbreak was likely one person infected. These millions of people was scaled up from one person, from this pangolin somewhere, which tells you wet markets need to go away. Those bye-bye wet markets, given what we've seen happen with SARS-CoV-1, SARS-CoV-2, and similarly, Some of you have heard me talk about Ebola before. You know, bushmeat causing Ebola outbreaks, likely source of Ebola outbreaks, and bushmeat was also the likely source of the HIV outbreak. So we need to find better ways to distance people from the risks from these animal-borne diseases, and wet markets is one way to distance them. So yes, the SARS coronavirus 2 is related, but is related to SARS coronavirus 1, not completely related, but they're still in the same exact subgroup. So close enough for all intensive purposes. So the signs and symptoms, most people know these well at this point. For the most part, a illness of your lungs. So it starts off in the upper respiratory tract, moves down into your lower respiratory tract. That's the disease that we're concerned about. So fever, difficulty breathing, coughing, tightness in the chest. What it's not is, it's not a runny nose, sneezing, sore throat, right? So this isn't sort of your typical allergies or typical upper respiratory influenza-like illness. This is a respiratory type illness. Most people, the majority of people get better. However, we do know that you're more likely to see complications among the elderly and individuals who have underlying health conditions, lung conditions, heart conditions, diabetes, for example. Now, there's a number of similarities between this and SARS, so I want to sort of match those back to you to link back to the discussion about SARS. So again, with this disease, we have continued to see these super spreading events. So here's an example. What is this example? Oh, this is the South Korean example where they did wonderful contact tracing and lab testing on hundreds of thousands of people to try to understand the nature of their outbreak in South Korea. And they had their first cases about the same time we had our first cases, and you know, they did an excellent job about that rapid laboratory testing, which was really needed. And so here at the bottom you see this patient number, famous patient number 31, could have been responsible for over 100 cases in the church there in Daegu City. So a super spreading event. Here's an example in Washington State where a choir rehearsal may have had a super spreading event causing 45 people getting infected. And I've seen numerous such reports. Churches across the United States, funerals, lots of events now being reported. A Biogen conference in Massachusetts, so lots of events being reported across the United States of these super spreading events, which are really devastating for the community because they increase cases within the community, but they also send cases out from the community to other communities. The other similarity back to SARS, which is very tragic, doubly tragic, is healthcare workers infected. So one, you have individuals infected, but two, you have the people infected who are supposed to take care of you if you get infected. And this is pretty tragic. Over 9,000 healthcare workers have been infected in the United States. We realize this is not a complete number yet because there's not really a good system to help us understand how many healthcare workers have been infected in the United States, and 27% of them have died. Now, we recognize that of those for whom there are data, they've not all been exposed in the healthcare setting. Obviously, they also have community risk, like any other of us have community risk. But this goes back to the fact that we need to make sure we're protecting healthcare workers with adequate PPE. And this is what has been the driver for this outbreak, right? And every death is tragic, and we have way too many of them with this outbreak. But we need to make sure, and what we didn't have was enough healthcare capacity. As I said, when I went back to showing you that data on looking at preparedness in the United States, we did not have a prepared healthcare system. And when you were listening to all the reports coming out of New York City, no PPE, no ventilators, no ICU beds, right? We did not have that capacity. And that's what got us in trouble with this pandemic. Let's look at how infectious this disease is. So here is COVID-19. So its infectiousness is probably maybe a little less or about the same as SARS, but it's not measles, right? So the most infectious disease is measles. 16 means one person with measles can spread it to approximately 16 other people. In general, COVID probably, if you're infected with SARS coronavirus 2 and you have COVID-19, you probably spread it to somewhere between 1.5 to 3.5 additional people. What gets us in trouble is those super spreading events when you spread it to a whole lot of additional people. And this is also called the basic reproductive number for those of you who like the geeky terms for this. So at this point, hopefully everybody on this who's listening to me is going, okay, Ellie, you've described a lot of the similarities between SARS and COVID-19, so why have we not been able to do the same thing with SARS, which is, we sort of put it back in the box after 6 months with 8,000 cases, and here we are with over 2 million cases with COVID-19 in 185 countries, and why are we having so much difficulty? Well, one of the main reasons we're having too much difficulty is that unlike SARS, with this disease, there's a lot of transmission that happens before you become sick. So SARS was mainly a healthcare transmitted disease, right? So as you became sick, you went to the hospital, you became increasingly infectious, and you started infecting people in healthcare settings and healthcare workers. With this disease, we believe, so this assumes that you're going to infect 2 people. So we believe, and if you look at some of the modeling data, that probably 40% of the people that you infect are, okay, sometimes it works, sometimes it doesn't, that smart word. 40% of the people you infect are before you become sick, okay? So this is very similar to measles and other diseases. So that's why it's so hard. If you're infecting people before you become sick, then you're out there in the community. So you're being a good citizen, okay? So I'm not talking about people who are sick and out in the community. I'm talking about people who are being good citizens. They're out and about the community doing the right thing, but they're still infecting people because they don't even know themselves that they're sick. So that's what's proven so problematic with this disease is what we call pre-symptomatic transmission. There's also probably a little of asymptomatic transmission, about 10%. So these are people who have no symptoms whatsoever, and they're also likely to be transmitting to people. And it's on the basis of this data that CDC changed its recommendation for people to wear masks. So the main reason they said they changed it is that if you happen to be one of those people who has no disease or is about to get sick in 2 days or 3 days, you're wearing a mask so you're not infecting other people. I say it's also for the purpose that other people aren't infecting you, right? Because this disease is mainly spread by droplets, so that's when you're talking to somebody, spitting, sneezing, coughing, and you want to keep those droplets out of your mouth and out of your nose. So masks are a good thing, and obviously part of our new normal out there to always wear masks. So this is what's made it very difficult to control this disease. And we'll go into the main reason why this has been problematic. So let me switch now to the U.S. Okay, so I've talked about where the disease started, the characteristics of this illness, the global picture, and now we'll sort of shift now to the U.S. and what's going on in the U.S. So I think these are yesterday's numbers, last night. So 750,000 out, so 750,000 cases in the United States, 40,000 deaths in the United States. And it looks like at this point we seem to be peaking in time in terms of cases and deaths in the United States, which is good news. It's better to be coming to a plateau than still going up. However, recognize that's still about 30,000 cases a day. That's a lot of cases that are still happening in the U.S. every day that we need to address and keep coming down. Now, what's interesting as I show this graph to people is that over a third of the cases happened up here in the New York, New Jersey area. But what's not been clear and there's so many questions remaining, is why other parts of the country didn't get hit as hard. So we're starting now to see a little bit more of the rural cases, including here in Nebraska, and I'll talk about that in a minute. But there's large cities in Texas, for example, that never had this similar, tens of thousands, hundreds of thousands of cases that we saw in New York City and New Jersey. And we know everybody in the world is susceptible to this disease. So that makes everybody concerned that maybe there's other waves of infection that will continue to sweep over the United States because everybody is still susceptible. So this may just be a pause as opposed to being done. Here's just a graph to show you what cases have been doing in the United States. So fortunately, we're not on this up anymore, but we're still on this sort of plateau sort of phase, and would like to go back we'd like to be on the down end of that. And we'll talk a little bit more about how to stay on the down end and not go back up again. So here's some of the characteristics of COVID-19, and as a public health professional, I can't not let go of the opportunity to talk about social justice and how this disease once again has exposed some of the social inequities within our society, and around all sorts of things, right? People who don't have health care, people who don't have time off from work. So there's also sort of social inequities that have been exposed. But even with this disease, for example, we know of large outbreaks going on in the Navajo Nation right now, and African Americans, for example, have been at least twice as likely to get infected and die as their proportion within the U.S., and this is still limited data. So again, these inequities in our society rear their ugly head again and again, and this disease has exposed them once again in our societies. There was the hope in the early days of COVID-19 that, maybe just 1% of people will die, and it's just like flu, don't worry about it. So I show this for those individuals who think this is a mild disease that they have nothing to worry about. So in the United States, our case fatality is 5.3%. That's pretty significant, right? 5% of people who are getting this disease are dying. And globally, it's 6.8%. So these are significant number of people who are dying with this disease. And I realize we're not testing everybody, so this number is likely lower. But even in places where they're testing everybody, like Germany, it's 3.1%. So really, still significant number of people who get this disease die. And if we think that the case fatality for influenza is 0.1%, 3 compared to 0.1, big difference. So again, not a disease to be minimized. So this is to answer the question, why are you all listening to me at home instead of at the slowdown eating pizza, right? Which is the version of the which is the version of the science cafe that I like better, okay? Is with pizza. Okay, and we're doing this today via Facebook Live, probably because of this, right? So we had the strategy in the United States of this social distancing and lockdown is because we had inadequate testing very early to make sure we could identify every case that was in the U.S., isolate them, find their contacts, and quarantine them. So we didn't have that robust public health response from day one that would have likely kept cases very low in our community and allowed us maybe to do less severe level of social distancing, but maintain some level of economic activity like Sweden, for example, has done, and other countries have tried. Like South Korea, for example, just had elections a couple of weeks ago because they had done such a good job. And it all comes down to testing. So it took us 47 days after the initial sequences were announced for this virus for the CDC to release widely testing in state labs, and that was quickly followed by permission by FDA for anybody to start testing, essentially to create laboratory-derived tests. But testing really, if I had to link two things, I would say testing and lack of data. Those are the two key things, I think, that define why we're all sitting in our living rooms right now. And hopefully those two are being addressed, and I'll talk a little bit more about that right now. But other countries that really had lots of robust testing found themselves in different positions and able to open up a lot earlier. And this talks about where we are in testing now. So obviously a lot better. So the United States testing levels now meet South Korea's testing levels, and others, Canada, Italy, Spain, etc., still testing more than we are. But we're testing about 1 million people a day now. We probably need to be testing, my guess would be about 3 to 5 million, 1 million a week we're testing. My guess is we need to be testing 3 to 5 million a week to make sure because the 1 million is not homogeneous across the whole United States. But if we're testing about 3 to 5 a week, million a week, I think we'll have enough testing to be testing everybody and really have a good sense of what's going on, and then couple that with good isolation of people who are cases and contact tracing. So we're getting better, absolutely much better. Back in March 3rd, we had 102 cases in the United States, and I think we had tested 6,000 people. We've come a long way to 3.6 million tests at this point. Okay, so let's transition to Nebraska. So this is, I think this is today or last night. So we have 1,648 cases in Nebraska, 33 deaths. There's a couple of different models out there to give you a sense of what's happening in Nebraska, but clearly cases are still increasing in Nebraska. You can look at the University of Washington model that suggests we have another week or two to peak within the state with 200 to 300 potential deaths. The same thing if you go to the University of Nebraska, UNMC website, not University of Washington, in this case University of Nebraska, you'll see similar projections if we don't get this outbreak under control here. So that's where you can get some sense of projections of where we're going. But there's a lot of efforts going on in the state right now to address these cluster of cases, and I'll talk about that in a minute. Let's see what's next. So this is where we are right now, 1,648 cases. Let me see if I want to do that. What's next? Yeah, let me do that. So this shows you what's going on with cases in the state, and you can see that we're still on an upward trajectory of cases within the state. Let me go back to this one because I think this one shows it better. So currently, what's driving cases in the state is actually these essential businesses in rural parts of the state, including meatpacking facilities and some long-term care facilities. And this is not unique to us in Nebraska. We're seeing this in other parts of the United States, and there's a lot of efforts on the part of the state and local public health departments to go out and address these facilities and think about what we can do to help them decrease cases, help them increase their efforts around around reducing people getting sick within those facilities. So there's a lot of work going on right now by our local and state health department to address that, but that's some of the Hall County, Dawson County, etc., some of those clusters that those who are probably listening to me today are reading about in the newspaper, but there's a lot of work going on by your absolutely excellent state and local health departments, state health department and local health departments to try to address what's going on there. So we can try to plateau. What we're trying to do is sort of get to the plateau in Nebraska. Testing has picked up in Nebraska, so we're about 1,000 tests a day in Nebraska, so that we've been very fortunate that that's picked up and there's more testing coming online in Nebraska. Also, this shows you that, this was from a couple of days ago from a newspaper article, but it makes the point that while Douglas County, which is here in Omaha, may be stabilizing to some extent, what we're seeing is some of these additional cases. This is Hall, but I could have now mapped a couple of other counties with this to show you increasing cases in some of these other counties going on currently because of the outbreak. Now, since I'm here at the University of Nebraska Medical Center for this Science Cafe, I have to talk about some of the work that's also going on, not just at your great state health department and local health departments, but also going on here at UNMC, including at the Global Center and the great work they're doing to support the state and local health department. I want to give kudos to all Nebraskans. So January may seem like a really long time ago to you, but when lots of the U.S. was saying no to letting anybody into their community who was infected with COVID or potentially infected, Nebraskans were generous enough to invite these people into their communities. So when we rescued Americans from Wuhan, Nebraskans said it was okay to bring them into their community, and they came into Camp Ashland. When we rescued these people from the Diamond Princess who had infection with COVID-19, Nebraskans were very generous to allow them to come to Nebraska, and they came here to our containment facilities and our quarantine facility here in Nebraska. So I want to give a shout out to Nebraskans. Thank you very much. I remember reading in newspapers of states essentially trying to sue the federal government or state government on how dare you let patients come to our city or state, come to our city. And now, there's cases all over the U.S., right? But you were very kind, you were very generous to these individuals, and hopefully we have maintained that trust for you by not obviously infecting others in the community by these patients who have come into our facilities and made sure that they have good care. But in addition to taking care of providing excellent care to individuals with COVID-19 or people who need to be quarantined, we have been pushing the research, so drug trials for people who may be infected with disease. Where Dr. Lowe has done some work looking at whether or not you can reuse some of these protective equipments because they've been in limited supply using UV light. Not the stuff you have at home. This is the industrial grade stuff, so please don't try that at home. But using UV light, we've been looking at how people's immune response happens over time. We have been supporting state and the local health departments with student volunteers here from the College of Public Health, College of Medicine, College of Nursing and Pharmacy, to allied health, dentistry, to do contact tracing, and other activities. So again, a lot of work going on here to help support the effort here in the state to help us decrease cases and allow us to go back into whatever this new world, this new normal will look like. So let's talk about that new normal and end with that. How do we get to the new normal? So this is some of the early models, and I use them not for the specific numbers, but to give you a sense of the ideas of what we need to do to try to get back out of our homes and get back to our regular lives. So what we decided appropriately was we were not going to do this. So this black curve is the do-nothing curve, or the herd immunity curve, which is, let's let everybody get infected. At 5% case fatality in the U.S., that would be a lot of dead people, right? And so that's not a strategy that any country decided to adopt, and instead they decided to adopt some versions of case isolation, quarantining, closing schools, social distancing, etc. And so these are different versions of mitigation, suppression, containment strategies. And pretty much what everybody has come to at this point is what the Chinese have always done, which is a containment strategy, what many of our countries in Southeast Asia have done, which are containment strategies, which is how do you find cases in the community, and this is what testing is about. So it's not about testing, it's about find cases in your community, isolate them, find their contacts, quarantine them, right? Protect your health system, protect vulnerable facilities, right? Healthcare facilities, healthcare workers, nursing home, long-term care facilities, businesses, etc. And so that's sort of this sort of suppression containment strategy. The biggest concern though remains what's called these secondary peaks, because everybody in America is susceptible, and unless either we truly eliminate, eradicate this disease like we did with the original SARS, or we have a new vaccine or some good drugs, we are going to do some version of what we're doing now for a very long time. But I want to end with hope, right? So I like to remind people, just don't look at what's going on in the U.S., right? We are in the third phase of illness. So that even though it's one pandemic, it's multiple epidemics in 185 countries in various phases. And even in the United States, it's 50 different epidemics in 50 different states. And in each state, even within each state, there's different outbreaks in each state doing different things in different parts of the state. So the first phase of the outbreak was Southeast Asia. In China, even Wuhan, the most affected city, is slowly opening up. And this is to show you the second phase was Europe. And this is Europe opening up. So these are pictures from Denmark, Germany, etc., showing you construction, small businesses, etc., opening up. So a new normal, lots of masks, lots of social distancing, people checking temperatures before you come into facilities. But, Europe is slowly opening up. So everybody listening to me, this is our future, right? We also soon will slowly start opening up. And again, it'll be very different from what it looked like back in January, but we will slowly start opening up. And for my colleagues in South America and Africa, they in 2 to 4 weeks will be also following along that sort of same path as we are, because they were the following waves of infection went into those countries. So opening up America again, there's a couple of different ways to think about this, and I'm going to share 2 different strategies or different ways to think about this. So the World Health Organization lays it out in these 6 steps. I sort of played with it a little bit, but all of them start, no matter who you talk to, it all starts in the same place. Get the disease under control, which is really about detecting cases. It's all about testing, isolating, control, right? Anything when anybody says get the disease under control, it means find those cases and kind of take care of them. Once you do that, make sure you have strategies to take care of hotspots, and that's making sure that you can surge healthcare capacity, ventilators, PPE, anything that needs to happen. Have you got prevention up going at schools, long-term care facilities, businesses, etc. One of the things I've heard about schools is we would go to a split schedule in school. So kids would go to school Monday, Wednesday, Friday, and then Tuesday, Thursday, Saturday, or something like that. So you had half of the number of children in school or something like that, right? So I think we're going to have to start thinking about different ways that we do things that socially isolate us at all times. You do need to manage imported cases. So China, South Korea, Singapore had all been doing a really good job at their own cases, and then they decided to repatriate some of their citizens who came back infected from other countries, and that caused problems for them. And then finally, what we need is you, right? We need educated, engaged, informed communities, because the more engaged you are in what's happening, the better we will be as we try to think about how do we reopen to make sure we do that in a healthy way that continues to protect everybody. The president outlines a 3-phased approach, and his phases are in are 2-week gates. And so the 2-week gate has to do with, are you having decreased cases? And so and you define decreased cases by defining fewer cases, or what are you doing as you look for lab testing or other signals of fever signals within the community, and do you have enough healthcare capacity? So that's his sort of gate, 2-week gate. Can you show the sort of decreased cases and you have enough capacity to take care of individuals if they get sick? And then if you can do that, so the first 2-week gate, you allow some vulnerable individuals always stay in until phase 3, but you allow some individuals who are not the vulnerable individuals out, and you allow some non-essential businesses, some essential businesses and some non-essential businesses to open by phase 2, so then you wait another 2 weeks, and then you allow schools to open in another 2 weeks, some more businesses to open. I think phase 2 is when bars start to open with lots of social distancing, and then you wait another 2 weeks, again showing more decrease in cases happening in 2 weeks, and then phase 3 you allow a little bit more gathering to be happening, although you're discouraging people from going to really big gatherings even in phase 3. And phase 3 is when you allow vulnerable individuals no longer to shelter at home. You still encourage them to stay away from any large gatherings at all. And then you lift most restrictions around people as they work and play routinely. In all of these, likely there's masks, social distancing, fever checks, etc. going on throughout all this. So that's sort of what the president's plan is. Now the expectation is that every governor will look at this, do the right thing for their own state based on where their state is, and it wouldn't surprise me that within each state the governor makes different decisions potentially about each county. I do know, for example, the governor of Florida has already opened up beaches in the Jacksonville area, for example. The governor of Minnesota has already opened up golf courses. So, again, this is going to be piecemeal rolling off of these social distancing guidelines across the U.S. based on how governors and their local public health officials are looking at their own individual data and what decisions they make based on that public health data. And I assume that's exactly what will happen here, that your governor working with his public health officials will make these decisions for Nebraska when we can roll off some of our social distancing guidelines. And until we roll off those social distancing guidelines, I would advise you to do exactly what you're hearing from Dr. Adipur if you're here in Omaha, or your local health official wherever you are in the state, Dr. Anton, Dr. Safranik, the governor. Please stay home, stay safe, stay connected until we can get through this and are allowed to be out a little bit more. Thank you everybody for joining me for this Science Cafe. Do
you want to take a couple questions?
Yeah, I'm glad to take questions.
Okay. A lot.
You have questions?
Yeah, you have a lot of questions.
I have lots of questions.
The first question is, how long with testing in Nebraska does it take to get your results?
So I had a wonderful conversation with Dr. Safranik today on a conference call, and he's saying that the turnaround time has markedly increased almost to the next day, almost potentially to the next day for some of these tests. So it's sped up a lot.
Nice. The next question is, a lot of questions actually about this, about a second wave, which you kind of hit on. Do you expect a second wave to come if we open too early or months down the road, or is there any way to predict that? But do you think for sure there will be a second wave?
So the second wave, the premise for the second wave is that we are still, all of us in America, worldwide, susceptible to this disease, right? So except for those who have been infected, and we will be doing testing, and we're already doing testing here in Nebraska, and we'll be doing it all over the U.S. to see how many did get infected. But if we haven't been infected, then we are susceptible. And as we open up, then the expectation is that unless we're doing a really good job of finding cases, they will infect. As you open up, people will start to infect each other, and then you sort of build up people who are infected until you start getting that second wave. I can tell you, based on everything I'm reading, that when you look at the wave that happened in New York City, probably they had cases going on for about 6 weeks. So somebody went back, looked at the genetic data, and it looks like that for 6 weeks they had people, probably the New York wave was Italian. So cases from Italy that sort of spread sort of a little low level in the community and then sort of took off. And that's the concern, is that as you open up, you have sort of low level spread that you're not finding, and then it takes off. So yes, that is exact concern, that if we don't do this smart and couple it with finding cases, that they build up in the community and they lead to a next wave.
Yep. Once you contract the disease, are you immune from it?
That's an excellent question. And the answer is yes. You're likely immune to it. What we don't know is how long you're immune, right? So we do know, for example, with the cold viruses, you're not immune forever. You get those viruses again. The cold coronaviruses, you get them again. so that's one thing. So we don't know how long you're immune. We also don't know how to measure how you're immune. So everybody's optimistic that some of these blood tests that people are purporting to use, these antibody tests, may show you're immune, but we're not sure they're any good. And actually, a lot of them, the European unions have rejected them because they're no good at all. And we've seen some studies, for example, that suggest 1/3 of people who have a coronavirus infection, COVID-19 infection, don't really have any antibodies at all, have very little antibody to test. So again, yes, you're likely immune. We don't know how long, and we don't know how to measure it really well yet.
How do people get the virus that have had no contact with anyone with the virus? Do you know?
Yes. So two things. So as I said, what's really been bedeviling us with this disease is that you can get infected by somebody who's fine. So you may think you've been interacting with healthy people, but they really are infected. So they could either get sick 2 days later, and you don't know they got sick 2 days later, so that's called pre-symptomatic transmission, or they're asymptomatic, and you got infected from them. So that's one reason, two reasons. And the third, less likely reason is from contamination from a surface. So somebody contaminated something that you touched, and then you got infected. And that's why we have this whole message about hand washing, hand washing, hand washing all the time. Don't touch your face, don't touch your mouth, don't touch your nose.
Good. Okay.
And wear a mask.
Yes. Next question. Hold on one second. My question went away. Ventilators. I know we are working on things to reuse PPE stuff. Is there any way that we can sanitize these ventilators to be put into like a national stockpile once we've used them so that we have them? Is that like something we're doing or maybe thinking about? Or
no, we are actually we are doing. So ventilators are you don't throw away a ventilator after you use it. The disposable pieces get thrown away, but ventilators get used from patient to patient, and governors have been very generous actually sharing ventilators back to the stockpile so they can be sent to other states that need it. So that's actually the best practice, and it's already being done, is you just shift ventilators to who need it, and then you ship them back to who needs it next.
Nice. Okay. My next question is, someone who has had the virus, can you talk about any effects that they might have after they've recovered from it?
Yes, absolutely. So that's an excellent question. We only have 4 months worth of data at this point, but now with over 2 million people infected, it's clear that while the majority do better, like many viral diseases, the majority seem to do better, but there are a minority of patients that seem to have some long-term, 4 months, right? Long-term side effects, either in their heart, especially in their lung, maybe in their liver and kidneys, and in their brain also. Now we're hearing about people who may have neurologic complications. My expectation is that we'll establish registries of these individuals and then monitor them every 6 months, every year, and then over a long time we will really know what are the long-term complications of this disease.
This person wrote in that they are 64 and on hydroxychloroquine. Did I say that? Probably totally wrong.
No idea what that is.
It's for RA, rheumatoid arthritis. It's I think the drug that President Trump was talking about. Yes. Will it be helpful if they contract the virus?
So thank you for that excellent question. We already know people with rheumatoid arthritis who are taking this drug for their rheumatoid arthritis who have gotten COVID-19. So I'm sorry, sir, it's not a guarantee that you will not get disease, and I would not recommend that people start taking hydroxychloroquine for prophylaxis. Actually, I would recommend that nobody take hydroxychloroquine unless you are in a hospital as part of a clinical trial.
Let's see, you kind of answered that. Any ideas why there wasn't increased regulations or additional oversight on the wet markets after SARS and H1N1?
That is an excellent question, and I like the fact that somebody connected to H1N1, which I did not. So thank you very much for connecting the wet markets, because the wet markets also don't have to do with SARS, they have to do with avian influenza, because that's where you buy your chickens, right? And that's where you can get avian influenza from, is the live markets for chickens. I think this has always been a cultural issue in many countries, that you do not go buy your, saran wrapped chicken at the Kroger. You go find the nice live chicken and you buy the nice live chicken, or you take it home and you kill it or whatever. I think that is changing. From everything I'm hearing, that in China the pressure's on to sort of cancel those wet markets. I think this needs to be a global effort now to say, all slaughter needs to happen in certified abattoirs, and and that's where all of these animals sort of are dealt with, so that people are not having direct contact with these animals in wet market settings. Obviously, we'll have to think about outside of those settings, but yes, wet markets need to go bye-bye.
Can you expect us to see maybe hard waves of mental illnesses and other chronic diseases, as our health system is already exhausted and patients are not going to their appointments?
Absolutely. And that is an absolutely brilliant question. So I get asked this all the time about elective procedures, right? And the only difference between an elective procedure and an emergency procedure is that it's planned. But elective procedures include people who need their surgery for their cancer, who need their surgery for their hip replacements, etc., etc. So elective does not mean unnecessary medical procedures, right? It just means it's not an emergency. So we do need to get back to when we can provide people their routine health care, and I'm very concerned that we have not been able to resume our routine health care for people. I'm worried about, from all sorts of standpoints, kids who can't get their immunizations, or parents are worried about going out and getting their immunizations. So we need to figure out, how do we get our healthcare system protected? How do we make sure we have a robust system to move people with COVID-19 into certain streams of care, and then so that other people can continue to get their regular health care? I also worry about everybody being at home all these months, and what are the mental health implications of being home all these months alone for some people. So yes, absolutely, real significant issues.
What about possible symptoms of loss of smell and taste? Are those legit symptoms to this? And is it true that maybe some GI symptoms might show up before even that?
So absolutely, the loss of smell and taste are very legit symptoms. Some people may think actually up to a quarter of individuals may have usually the loss of taste is associated with the loss of smell. The receptor to which the virus binds is found in the nose. It's the ACE2 receptor, and that may explain why you're having the loss of smell. Those same receptors are also found in the gut, which may explain some of the GI symptoms that people are experiencing.
I'm sure there's more questions that I just missed, but anything else you want to add?
No.
All right, then we'll call it good. We'll put your presentation maybe on our website for people, if you're good with that.
Absolutely.
All right, well then we're going to end this. So thank you, Dr. Khan. Thank you guys for watching.
Thank you, Nebraska. Always a pleasure.
All right, and hold on.